Hey everyone, welcome back to Shock Doc Medical. I'm Dr. Rad, and today we've got a monster episode that's going to blow your mind. Have you ever wondered how one breakthrough study could completely reshape our approach to treating viral respiratory infections? Buckle up, because we're about to embark on an in-depth journey through the latest treatments and the challenges of combating these pesky viruses. Let's kick things off by taking a look at the big picture. Viral respiratory tract infections, or RTIs, are the #1 reason people get colds, flu, and even pneumonia. While we have a truckload of antibiotics for bacterial infections, our options for viruses have been, until recently, pretty limited. For decades, our antiviral arsenal for respiratory viruses was confined to just 3 major drugs: amantadine and rimantadine for influenza A, and ribavirin for RSV infection. Amantadine even dates back to 1966. Then, in 1999, the game started to change with the arrival of zanamivir and oseltamivir, new anti-influenza agents that sparked both hope and controversy. Some countries even balked at reimbursing zanamivir, and the UK's NICE was initially hesitant to recommend it for widespread use. Now, with several new therapies in late-stage clinical development, it's time to take stock of where we are and where we might be headed. Now, viral RTIs aren't just one disease. They're a whole spectrum. The common cold, or coryza, is usually caused by rhinoviruses, which have over 100 serotypes. But get this, about 20% of colds are due to coronaviruses, and similar symptoms can also be triggered by influenza, parainfluenza, adenoviruses, RSV, and even enteroviruses. These viruses can also move down the respiratory tract. For instance, adenoviruses are notorious for causing pharyngitis and tonsillitis, while parainfluenza is the main culprit behind croup, a condition where swelling in the larynx makes breathing a challenge. And for those with chronic conditions like COPD, asthma, or cystic fibrosis, these viral infections can lead to acute bronchitis or even exacerbate their existing issues. Infants, especially, suffer from acute bronchiolitis mostly due to RSV, and while viral pneumonias are rare in healthy individuals, they're a serious problem in the elderly or immunocompromised, often involving herpes viruses like CMV or HSV. Even HIV can complicate matters by increasing susceptibility to other lung issues like emphysema. All right, let's zoom in on the common cold and its viral troublemakers. Historically, researchers at the British Medical Research Council labored for 43 long years without finding a cure for the common cold. Early on, several compounds showed promising anti-rhinovirus activity in test tubes, but they just didn't hold up in clinical trials. There was also work with A and BA interferon administered intranasally before exposing volunteers to viruses like rhinovirus, coronavirus, influenza, and RSV. While these interferons could protect against infection, they came with local side effects and were only really effective as a preventive measure, not a cure once you're down with a cold. But then came a breakthrough. Scientists discovered a deep surface depression, a canyon, on the rhinovirus, which is where the virus attaches to our cells. This led to the development of a new class of drugs. One star of the show is plecanaril, Win63843. Plecanaril binds to a hydrophobic pocket in the virus's canyon, essentially locking the viral capsid in place and preventing it from uncoating. It boasts excellent oral bioavailability, reaches high levels in the nasal epithelium, and in clinical trials, reduced the duration of symptoms by about 3 days in some studies. Other studies showed a 1 to 2.25-day reduction, especially in patients confirmed to have P. coronavirus infection by PCR and not on other cold medications. Another promising agent is AG7088, a rhinoviral 3C protease inhibitor developed by Agoran Pharmaceuticals. In volunteer studies, AG7088 was given intranasally up to 6 times a day and was well tolerated, with phase 2 trials showing significant reductions in symptoms, nasal secretions, and even viral concentrations. Meanwhile, companies like Lilly and others are exploring similar protease inhibitors, though most of these are still in the preclinical stage. And here's another clever strategy. Since about 90% of rhinovirus serotypes attach to a receptor called ICAM1, researchers at Boehringer Ingelheim and Bayer engineered truncated soluble forms of ICAM1. One such product is trimacamra. When administered intranasally, trimacamra effectively neutralizes the virus by binding to its attachment sites, significantly reducing cold symptoms in phase 2 trials, whether given before or after exposure. The challenge, though, is that these molecules have a short residence time in the nasal cavity due to sneezing and mucociliary clearance, which means they only protect against 90% of rhinovirus strains. Switching gears to influenza, let's talk about our classic drugs and the exciting new ones. For a long time, amantadine and rimantadine were the go-to treatments for influenza A. They work by interacting with the M2 membrane protein, a sort of ion channel crucial for the virus's life cycle. But there are some big limitations. They don't work on influenza B, since it lacks the M2 protein, and come with central nervous system side effects, particularly with amantadine. Rimantadine tends to be a bit kinder on the brain, but both have shown fetotoxicity in rodent studies. Nebulized administration was tried to improve safety, but it never really caught on. Plus, resistance to these drugs develops pretty quickly, often due to just a single amino acid change in the M2 protein. Enter ribavirin. This broad-spectrum antiviral nucleoside is active against both influenza A and B in vitro. Oral ribavirin hasn't been very effective clinically, but when delivered via nebulization, it has been shown to speed up recovery from influenza infections in infants and young children. However, ribavirin is not without its downsides. It's expensive, and the standard regimen involves nebulizing for a whopping 12 to 18 hours a day, though some studies suggest that a higher dose, shorter duration approach might work just as well. Now, the real revolution in anti-influenza therapy came with the neuraminidase inhibitors, zanamivir and oseltamivir. Zanamivir has very poor oral bioavailability, so it's administered by inhalation using a dry powder inhaler known as the discaler. It's typically dosed twice daily and has been shown in clinical trials to shorten the symptomatic period by at least a day, reduce the need for over-the-counter meds, and even lower antibiotic use for secondary infections. A slight drawback is that because it bypasses the nasopharynx, it doesn't seem to affect complications like sinusitis or otitis media. On the flip side, oseltamivir is well absorbed orally, distributes widely throughout the respiratory tract, and has a plasma half-life of about 8 hours, supporting a twice-daily dosing schedule. Studies show oseltamivir can shorten symptom duration by around 1.5 days and is even more effective than zanamivir in reducing antibiotic prescriptions. Both drugs are generally well tolerated, though there have been a few isolated reports of bronchospasm with zanamivir. And don't think we're stopping there. New neuraminidase inhibitors like RWJ27201, BCX1812 are currently in phase 3 trials, and companies like Abbott Laboratories are exploring novel pyrrolidine-based inhibitors. There are even other compounds derived from podocarpic acid and antisense phosphorothioate oligonucleotides, showing promise against influenza A, though some, like Provire, SP303, were dropped due to poor oral bioavailability. RSV, or respiratory syncytial virus, is a particularly tough nut to crack. We still don't have an effective vaccine, especially after that infamous formalin inactivated vaccine in the 1960s, which not only failed to protect but made things worse. For now, the front line for preventing severe RSV in high-risk infants is prophylaxis with either hyperimmune globulin or the humanized monoclonal antibody palivizumab. Palivizumab, for instance, has been shown to reduce the replication of RSV in the tracheal secretions of ventilated infants. But note, it's used only for prophylaxis and isn't licensed for treating an active infection. Plus, its high cost raises questions about cost-effectiveness in most premature infants, with or without chronic lung disease. For treating established RSV infections, ribavirin remains the only approved therapy. Administered by nebulization for 12 to 18 hours daily, ribavirin has demonstrated improvements in clinical signs, oxygen saturation, and even reductions in the duration and severity of the illness. However, many of the studies are small, and their designs have been critiqued, with some mixed results on long-term lung function. Its use is generally reserved for high-risk infants with existing cardiopulmonary issues or immune deficiencies. There's also been some research into Ha interferon, given either intramuscularly or as an aerosol, with modest benefits, but that hasn't really taken off as a mainstream approach. Other novel agents, like a nebulized antisense oligonucleotide, NIH-315, and several compounds targeting the RSV fusion protein, like the biphenyl derivative CL387626 from Wyeth Ayerst and VP4637 from Viro Pharma, are in the early stages of development. Now, let's shine a light on some of the rarer viral infections. Consider juvenile laryngeal papillomatosis, a condition caused by the human papillomavirus. It's rare, affecting roughly 2 per 100,000 people in the US, and leads to recurrent papillomas in the aerodigestive tract. This can cause hoarseness, stridor, and even respiratory distress, and in some cases, progress to malignancy. Conventional treatment involves frequent endoscopic surgeries, but there's been promising work with intramuscular HOF interferon, which has produced sustained or repeated responses in many patients. Anecdotal evidence also hints at benefits from ribavirin and acyclovir, though a really promising approach seems to be the use of cidofovir, administered either intralesionally or intravenously. Then there's hantavirus, a virus known for causing hemorrhagic fever with renal syndrome, but which in 1993 surprised us all by causing severe respiratory disease in the southwestern United States, marked by non-cardiogenic pulmonary edema and a high mortality rate. Intravenous ribavirin has been shown to reduce mortality in cases of HFRS, but in hantavirus pulmonary syndrome, its effects were less dramatic. Interestingly, treatment with corticosteroids has shown promising results in South America for this syndrome. For our immunosuppressed patients, think bone marrow or solid organ transplant recipients, the stakes are even higher. These patients are particularly vulnerable to severe viral RTIs caused by community viruses like adenovirus, influenza, parainfluenza, and RSV. On top of that, they often suffer from severe herpes virus infections, especially due to CMV and HSV. In these cases, while there are no approved agents specifically for parainfluenza or adenovirus, ribavirin has been used empirically with varying success. For CMV, prophylaxis with ganciclovir has proven valuable in both bone marrow and solid organ transplant patients. And when it comes to treating established CMV pneumonitis, combination therapy with ganciclovir plus immune globulin has shown significantly improved survival compared to using either agent alone. Alternatives like foscarnet, though limited by renal toxicity, and cidofovir, currently in clinical trials, are also in the mix. There's even some cool research on novel agents like BAY384766 and a bioengineered proteinase inhibitor called OT1-PDX, which is highly active against herpes viruses in cell culture. For HSV pneumonitis and varicella zoster virus infections, acyclovir remains the recommended treatment, even though high-dose acyclovir combined with alpha interferon was ineffective for CMV pneumonitis post-bone marrow transplantation. Newer drugs with better oral availability, such as famciclovir and valacyclovir, might soon become the treatments of choice for these infections. Now, let's talk about the elephant in the room: antiviral resistance. Resistance to drugs like amantadine and rimantadine has been known for decades. In fact, resistance to amantadine was documented as early as 1970, and rimantadine resistance followed in 1987. These drugs can become ineffective due to a single amino acid change in the M2 protein, which not only affects treatment outcomes, but also complicates the prophylactic use among contacts. Interestingly, while resistant influenza viruses have been transmitted in settings like families and nursing homes, they rarely persist in the community because of the constant emergence of new strains. In contrast, ribavirin has not demonstrated viral resistance, probably because it works through at least 3 different mechanisms: depleting nucleotide pools, inhibiting mRNA cap formation, and interfering with viral RNA polymerase. For neuraminidase inhibitors like zanamivir and oseltamivir, resistance can develop in vitro, but it occurs much less readily than with the adamantanes. In fact, zanamivir resistance has been documented in only one case, a report in an immunocompromised child, and oseltamivir resistance is seen in less than 1% of treated patients. With herpes viruses, resistance tends to crop up with prolonged monotherapy, particularly in immunocompromised individuals. So, what's the takeaway? Much like in bacterial infections, monotherapy in acute viral infections in people with normal immune systems rarely leads to significant resistance. However, in chronic infections, especially in the immunosuppressed, combination therapy might be the smarter route. In fact, combining drugs like ganciclovir and foscarnet for high viral load CMV patients has been proposed, aiming to achieve additive or synergistic effects while reducing the likelihood of resistance. Here is the exact text you requested. Let me give you a quick rundown of the key viral pathogens and their treatments, straight from the research. Rhinovirus, no currently approved therapy. Agents under investigation include TICAMs, like tremacamra and BIS9700, plicanerol, and AG7088, the latter given intranasally up to 6 times daily. Influenza A, approved agents, amantadine and rimantadine. Influenza A and B, approved agents, zanamivir, administered via inhalation twice daily, and oseltamivir, oral twice daily. Also, ribavirin is used, although its nebulized regimen is typically 12 to 18 hours daily. New agents under investigation include RWJ-270201, respiratory syncytial virus, RSV, approved therapy, ribavirin. For prophylaxis, palivizumab is available, though its cost and licensing issues limit its use. Parainfluenza and adenovirus, no approved therapy. Ribavirin is used off-label. Papillomavirus, recurrent respiratory papillomatosis, no approved therapy. Treatments under investigation include interferon and cidovir. Hantavirus, no approved therapy. Ribavirin has shown promise, and corticosteroids have yielded positive results in South America. Cytomegalovirus, CMV, approved therapy, ganciclovir. Other agents include cidofovir, immune globulin, and foscarnet. Herpes simplex virus, HSV, and varicella zoster virus, approved therapy, acyclovir. Alternatives with better oral availability, famciclovir and valacyclovir. This table gives you a bird's eye view of where we stand in treating viral RTIs and highlights the exciting developments on the horizon. Wow, that was a deep dive into the ever-evolving world of viral respiratory infections and their treatments. We've covered everything, from the common cold to severe infections in immunocompromised patients, and even tackled the thorny issue of antiviral resistance. The takeaway here is that while we've come a long way since the days of amantadine and ribavirin, the field is rapidly evolving. New agents and combination therapies are on the horizon, and with smart dosing strategies, like using AG7088 up to 6 times daily or nebulizing ribavirin for 12 to 18 hours, we're learning to outsmart these viruses. If you found this deep dive as fascinating as I did, hit that like button, subscribe, and leave your thoughts or questions in the comments below. I love hearing from you and building this community of curious minds passionate about the cutting edge of medical innovation. And hey, don't forget to tune in next week, because we've got another groundbreaking topic coming your way that might just change everything you know about modern medicine. Until then, this is Dr. Rad from ShockDoc Medical. Stay informed, stay curious, and keep challenging the limits of what you know about health and science. Catch you on the flip side.